From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
Wonderful. Welcome to the Crisis Jam. My name is Megan Haupt. I'm Chief of Staff for the National Association of State Mental Health Program Directors. You are joining Season 6, Episode 239 of the Crisis Jam, What They Don't Teach You in Addiction Psychiatry. That's what this theme is today. We are thrilled to have Dr. Rochelle Head-Dunham do a fireside chat with Joy Brunson-Nsubuga to facilitate that. So very excited about this episode. Let's go to the next slide. And so one of the things we did in the backstage pass, which is if you join early, there are videos and conversation. And one of the things we did was a sound check. And we love to do that with our audience here as well. What's the biggest challenge on your plate right now? If you put in the chat, what's the biggest challenge on your plate right now? That could be personal or professional. Just what's your biggest challenge? Some people, it might be the government shutdown. Some have said it's staffing. Some is finances. Some funding for community mental health services. So just go ahead and put that in the chat as we move along. We're all going through challenges. Whether they're good times or bad, there are always challenges, and they certainly help us grow. They're not always easy in the moment, but we do get even better from them very often. We're seeing one thing consistent in life is change. Yes. So crisisjam.com, that is our website. It is a fantastic learning community, and it's about shaping the way we respond to crisis. So that's the website. You can tune in, log on, join the movement. You can watch previous episodes. There's a YouTube access, there are newsletters, Zoom. And this is an example of a past episode, Battle of the Bills between Senator Tina Orwell and Representative Steve Eliason. And they did just a great talk on a lot of the legislature that they have been working on and many successes, and they were able to learn from each other and teach us so much. So we encourage you to look at that website, and you can see some of the past episodes. We have different kinds. There are fireside chats, debates, there's live and on location, there are feature presentations. So please check this out, all kinds of different formats. And today is a fireside chat, so you get to see that. Love that kind of conversation and flow. Great. Great, and we're now going to go to the news, the breaking news. So we're going to go to Dr. Carol Olson. Dr. Olson is the chair of the Psychiatry Department for Valleywise. Dr. Olson, please go ahead.
Yeah, thank you very much for giving me this opportunity to talk a little bit about Valleywise Health System, which is a proposal on the ballot in November. It's an entirely mail-in ballot this November, and it's a proposal for the voters to authorize bonding capacity for the health system to have the funds for several urgently needed projects, one of which is very important for our behavioral health services. And for people who aren't familiar with what Valleywise is, Valleywise used to be called the county hospital, but many years ago, the voters approved to make Valleywise a special healthcare district. So it's not under the County Board of Supervisors in Phoenix and the Maricopa County. It is now governed by a healthcare district board that's voted on by the voters. And it is in part supported by a property tax that board approves on an annual basis to help support the operation of the hospital, because we're a hospital intended to serve the public as a safety net. And we have a particular mission to serve those patients who perhaps are not as desired patients in other local hospitals. What that means for our behavioral health services is that we have 392 beds currently that are almost all occupied by individuals undergoing court-ordered evaluation or court-ordered psychiatric treatment. And we have 3 hospitals that are providing those services. The part of, or a big part of this bond, if approved by the voters, would allow us to replace the hospital we have in Central Phoenix that's called the Psychiatric Annex, which is where we put people who have complicated medical comorbidities along with their psychiatric problems. It takes people who are on dialysis, people who require tube feeding, people who require physical therapy because they jumped out of a building and broke several bones, people who have various physical health challenges and need complicated interventions, both psychiatric and medical. That hospital is over 50 years old. It has rooms that take 4 people with showers down the hall. That's not an ideal environment for people who are in a psychiatric crisis. You could have a manic person who's up all night and quite noisy and disturbing of peers, but we don't have private rooms in that building. And it's required several interventions for asbestos and various other reasons just because of the age and when it was built. In addition to which, because Valleywise are the only hospitals in Maricopa County that accept people who require a court-ordered psychiatric evaluation, we constantly run full. And typically every day we have at least 40 people pending admission from the local urgent care center psychiatric emergency rooms. So as of this morning, I had 44 people who needed to come into the hospital on a very tight timeline that's specified by statute. If I do not have beds for those people, they end up either getting released to the community inappropriately, or if they have ongoing behaviors at one of those urgent care centers, they will need to have a new petition for court-ordered evaluation done on them, which really isn't fair to that person because they end up being detained without really getting their court-ordered evaluation for longer than really they should be detained. And they may be in that subacute crisis center setting when they really need to be in a hospital setting to have their evaluation. So so that's one big part of what the bond proposal would cover. In addition to that, it would allow us to build out the top floor of our acute care hospital. We have a new acute care hospital that was the bonding for that was approved by the voters about 10 years ago, and it just opened last October. But we didn't have sufficient funds to build out the top floor, and we really need those beds. So this bond would allow for that. It also would allow for expansion in our emergency room, which is also heavily used. We do a lot of medical clearance for the nearby urgent care center, as well as just serving our local public in our emergency room. And we're a level 1 trauma center there as well. So it's very busy emergency room. So Valleywise is hoping that the voters in Maricopa County will recognize the unique role that our behavioral health services and our other services provide for the citizens of Maricopa County, and authorize this bond to help us get these buildings built, because the current property tax that is voted on an annual basis, it can only cover the operations. It isn't sufficient to fund like capital projects like buildings. So I guess I have 5 minutes and I think I used it, but but anyway, that is what I wanted to present to everyone. They're actually in the voter information pamphlet. There was no one who was opposed to this bond that decided to put their concerns in writing. However, I have been speaking at several public groups, etc., and there's been a lot of concern about how, whether this is all going to care for people who are undocumented or concerns like that. And I tried to explain mental illness does not just afflict poor people or undocumented people. It afflicts people across the population. And this is a really important public service to provide care to people in need, regardless of who they are. And I'm hoping the voters will support it. But thank you for giving me this opportunity.
Thank you, Dr. Olson. Good luck to you on these efforts, for sure. And let's transition to Voices in Crisis Care. We have, we have Madeline Siggy and Akushka Visser both from the Netherlands. my understanding is it's almost 10 after 6 or 10 after 7 there. So thank you for taking your evening with us. Going to turn it over to you. And just wanted to get your reflections on last week's episode. Big feelings in the real world. Dr. Chuck Browning had facilitated this dialogue and just wanted to get your thoughts and reflections.
Thank you so much, Megan. And thank you very much for inviting us. I'm Moderator, and I'm coordinator at the Dutch Association of Mental Health and Addiction Care. And we represent mental health providers across the Netherlands. And through our partnership with the Global Leadership Exchange, I've had the pleasure of connecting with actually quite a few of you. And last week's episode on big feelings and restorative just culture really resonated with me, with us, especially the idea that safety grows when we repair, restore, and learn together after something goes wrong. And today, we'd like to build on that and share how within the Dutch mental health healthcare service providers, we are learning not only from what goes wrong, but also from what goes right through what is called the Safety 2 approach. And I'm joined by Anouska Visser. Thank you so much for being here, Anouska. She's a clinical psychologist and director at GGZ Delftland, which is one of our members as our association. And it's a mental health healthcare organization in the west of the Netherlands. So Anouska, could you start by giving a short picture of your organization and how you became involved with Safety 2? Over to you.
Yes, thank you, Madeline, and thank you for being here. It's a very great honor. GGZ Delftland provides a wide range of services, from outpatient to inpatient care, forensic psychiatry, youth and elderly care. We offer supported living and crisis services. GGZ Delftland employs around 1,900 professionals, and we have about 410 beds. And in the Netherlands, crisis care follows the high and intensive care model together with GEMAP, and that's like our national standard acute psychiatry, and both focus on connecting with the person in crisis and their loved ones, and tailoring the response to their.
And I think we're losing a little bit of connection there. I don't know if it's on my end or yours.
We just missed that we're tailoring the response to specific needs. Yeah.
Okay.
Yes. Oh, that's. I hope my connection stays throughout the rest of the. Yeah.
Wonderful. And just wanted to also get your thoughts on just culture. I don't know if you were able to kind of see that last time.
Yeah.
What do you all think? Mm-hmm.
Yeah. Well, the Safety 2 approach, it's very in line with the just culture, because it's about learning and reflecting on everyday work and all the thousands of things that go right because of the skill, the resilience and adaptability of our healthcare professionals. And instead of focusing on errors or accidents, and instead of focusing investigations on finding like a single root cause, we look at the broader context in which things happen. And that broader context is a work environment that is complex and unpredictable. And so we need to focus on what helps our professionals to succeed, even under pressure. And instead of viewing our people, our professionals, as the weak link, we need to actually see them as the source of resilience and resourcefulness that actually makes our complex care system work.
I love that, Anushka. A strength-based approach helps us go towards something rather than leaving something behind, or, every time I think we go towards a solution, I think it helps us move towards increasing that. So
Absolutely.
really appreciate your perspectives. Thank you both for being here. We do have to move along, but gosh, I hope you guys keep joining us. We love your perspective. Thank you.
Thank you.
Thank you for having us. Thank you. Bye-bye.
Great.
Bye.
Take care. And we're now going to bring up, we've got the Crisis Jam hot seat, and I believe we have, oh, yes, of course, the swag. If you create a team of 2 people, even more, for the Crisis Jam hot seat and the over-under, you get a special code to go into the Crisis Jam shop and get some swag. So encourage that, but plain, really, it's just fun. It's just fun. So let's bring up Laura Evans and Representative Steve Eliason from Utah. And I believe they are doing the hot seat together today.
Yes, thank you so much, Megan. You're doing a wonderful job hosting. But really, I'm in the passenger seat because Rep. Eliason is driving the train today.
And literally, he's moving around. It's like you're driving with him, right? Yeah.
Sorry, I actually just stepped out of a legislative hearing to join Crisis Jam. So
Absolutely. Representative Eliason, we are so glad you are on. Thank you for stepping out. We are so honored always to have you on. So thank you. I am going to read you guys the question, and then we'll go from there. Which of the following medications was the first approved by the FDA for the treatment of opioid dependence? A, is it, oh my gosh, I said this in rehearsal just fine. Buprenorphine. B, methadone. C, naltrexone. Or D, naloxone? What do you guys think? And audience, put your answer, audience, in the poll there, where you think it might be.
Rep. Eliason, I'm going to lean on you because this is not my area of expertise. I'm a policy expert, not necessarily a clinician. So what are you thinking here?
Well, my wife says that I only play a physician on TV since I'm not a clinician. So I don't feel qualified answering a medication-related question. However, one of my sons worked at a methadone clinic, and I know enough about these medications that methadone has been around for a very long time. So I'm going with methadone.
And that matches a lot of what we're seeing in the chat. So I'm going to endorse that and say final answer.
Great. All right. Well, 80% of the audience, you guys are so brilliant. Yes, methadone is what the audience answered. Let's take a look. Indeed. So improved in 1972, methadone became the prototype for medication-assisted treatment long before MAT was even a term. It paved the way for naltrexone 1984 and buprenorphine in 2002. So I, like you, Representative Eliason, I've always heard about methadone clinics, and that was my first exposure to this as well. So yeah, methadone. Good job, you guys. And I think we're going to move to the over-under.
Yes.
Sounds a little like my dog. I don't know. Okay, let's do the over-under. What is the question? Okay, so the American Board of Psychiatry and Neurology, ABPN, is the gold standard for expertise in lifelong learning and was established in 1934. So what year did ABPN officially recognize addiction psychiatry as a subspecialty? So one of you maybe throw out a year and maybe the other do an over-under on that.
Okay, Rep. Eliason, I'll let you throw out and I will I will endorse your answer or go over or under.
Okay. All right. Here we go. 1975.
Ooh, and why 1975? 1 year after methadone? What are you thinking?
Methadone, I think, was 1972.
Okay.
But yeah, that wasn't, I was just developing at that time. So I'm giving him a couple years to start building the kind of the field of practice and the knowledge base. So that's my best guess.
Okay. I'm feeling a little contrarian today, Rep. Elison, and I think it might take a little bit longer for folks to come around. Maybe I'm thinking society and not necessarily the science, but I'm going to say it was after 1975. So I think that's over.
Yeah. So, okay. So you're going to answer over. I love, it's always hard to put out the year. In rehearsal here, I put out the year and it's always like, what is it? You know, I get it. All right, let's take a look. 1993.
Wow.
Can you believe that? I said 1985, you know, before, and I really thought it would be like you, Representative Eliason, sooner after the methadone piece. So yeah, 1993. So great. Is there any additional information on that? I think there was something that happened in 1991. It's like when they started establishing it, but then it was more standardized in 1993. So wonderful. Thank you both so much for being on. Yeah, in the chat, you can see this. It says psychiatry was first approved in 1991 as a subspecialty, but it wasn't until 1993 when the first subspecialty examination was implemented. So you answered 1991 and 1993. Great job. That was 60 years after the ABPN was created. Interesting. Wow. Okay.
Now we know.
Now we know. All right. Thank you so much to you both. Really appreciate it. Thanks for being here. Okay. And I love this, that slide that was just showing. This is the Crisis Jam anthem. And we play this in the backstage pass, but we want to show it to you here. Just love it. And I love that anthem. Someone to respond, a safe place for help, and someone to follow up. As you know, someone to follow up is just critical to additional well-being. So we love that part. And we know that Dr. Richard McKeon from SAMHSA really has emphasized that. So love that anthem. All right, let's move ahead. Great, we're at the lead story. And this is so what they don't teach you in addiction psychiatry. We're really thrilled to have Dr. Rochelle Head-Dunham. I'm going to turn this over to Joy Brunson-Nsubuga. I'm so sorry. One day I will get that right. I promise. Okay.
You are so close. You are so close.
I know. It's so close. Yes. Go right ahead. Great to see you.
You as well. Thank you for having me. I have the pleasure of hosting or interviewing for this Fireside Chat, Dr. Rochelle Head-Dunham. There you are. Just a little bit of an introduction. Dr. Rochelle Head-Dunham is the Executive Director and Medical Director of the Metropolitan Human Services District in New Orleans, Louisiana. And I'm sure a whole host of other hats that she wears as well. But we are going to jump right in. So welcome, Dr. Rochelle.
Thank you so much. Glad to be here.
All right. So we have a very interesting topic today. And I think the title, What They Don't Teach in Addiction Psychiatry, is just very catchy. And so why is this topic important?
So I first of all, I want to thank RI for giving it space and place for conversation, because the absence of conversation around addiction psychiatry is sort of a subtle indicator that people think it's not important. The fact that we're giving it space and time clearly endorses the fact that it is hugely important. So why do I say that? First of all, it is the condition, a group of conditions that you have to think about in the context of psychiatric care, because it's usually there. In most cases, people who have psychiatric conditions, you have to screen for whether or not there's an addictive disorder underlying, which can look like just about the entire DSM can look like, can unfold if you have a substance on board. Additionally, it's hard to separate those things out, and there's a process for that in order to do a fair and equitable assessment and care for the person. The other thing is that addiction requires its own protocols for care. That 1993 endorsement of addiction as a subspecialty was hugely important, because it stamped the fact that you cannot go from general psychiatry to addiction psychiatry and do a fair job by the patient, because they're two very different brain disorders which require interventions that are learned. They're not intuitive. They're not vicariously known. You have to take the time, put in the years, put in the energy, get the experience in order to really understand how to treat this whole constellation of conditions. And then there's so many things that are complicated by addiction. So there is also the physical sequelae that occur, which in most cases are the reason why people pass or die, or why the morbidity and mortality is so high, is because of the physical consequences. Not so much the case necessarily for other psychiatric disorders, except that psychiatric conditions in general, people tend to neglect their physical health because of their mental status. But in the case of addiction, the target is critical organs in most cases. So it's absolutely critical that we talk about it, understand it, respect it, learn how to manage it, and save lives.
Yes. Yes, that is just so well said to like get us started. And it just reminds me of, I'm a therapist going through graduate school. We also had to select classes to learn about addiction. It wasn't just kind of a track that we were able to go on. It was something that we had to do separate if we wanted to know. So totally agree with everything that you're saying. And I think it fits across a lot of different disciplines as well. Let's think about how does addiction psychiatry then fits into the crisis continuum. Why is it important in this forum?
So, addiction typically is a crisis, whether it is one that's brewing because the person is at that early stage of trying it out. Young people, brain exposed to things like marijuana, is creating a brain crisis, because the brain is now having to resort and reestablish itself around how it is functioning in that dopaminergic system. It's being reset. And so that becomes a crisis for the brain itself, very quietly, but it starts there. It is a crisis, I think, in the most obvious way because of the overdosages that occur and the toxicity of the products. What people is important to understand is that our normal system of endorphins and pleasure has a ceiling on how much the normal brain can consume of that. The substances exceed that normalcy and create a new set baseline, which is almost impossible to reach unless you inject into your system these substances. And so it's a different brain. It is a hijacked brain. And I know people have heard that. It truly is a hijacked brain, because it becomes a space where you don't have willful control, which is why it's not a moral dilemma. There isn't choice at that point when the brain is literally changed in such a way that it needs that in order to function. So that's an emergency, that's a crisis scenario. And then every time a person is in a withdrawal state, they are in crisis. The opioid withdrawal is one of the worst, but it's not deadly, except in overdosages with fentanyl and things like that. But alcohol and benzodiazepines, those withdrawals can kill you. Now, it's also a crisis. The other reason why this is important is because trauma is so infused in addiction scenarios. And a traumatic experience creates crisis throughout life because there are challenges with how to cope, people's typical ways of balancing things in their brain and in their life. Their coping skills are not as healthy, and they engage themselves in and become engaged in scenarios that are crisis prone. And then the other thing is, it's often often associated with homelessness. And homelessness is a crisis state. And so all of these reasons are intertwined. In many cases, people are suffering from the triple crisis of all of those things. I'm in withdrawal, I'm homeless, and I have had trauma. In fact, my homelessness is the trauma that I'm living right now. So absolutely, it falls nicely in the crisis continuum spectrum.
Yes, you are dropping so many like nuggets of information today. I'm going to stay on topic, but just that homelessness piece. Homelessness is a crisis. That is something that needs like an exclamation point on it, because oftentimes that is seen as something just completely separate. Wow. Okay, but I'm going to stay on topic. So with everything that you're talking about and what wasn't taught in addiction psychiatry, so how does this factor into and impact access to care?
You know, Joy, one of the big problems with psychiatric or behavioral health conditions is stigma, right? Stigma is so ubiquitous in terms of the many, many opinions about people who are less or have less. And we don't go the distance for people like that. We don't make the same services available for them. And even if the services are available, they're sparse and far in between. They're not available to them in the areas that they are in, or they just can't afford it, or they don't have insurance coverage because their lives aren't stable enough to apply and keep up with all of the renewals and so forth. And so access is not just about creating a space where people can go for services. You have to deal with the person's ability to become ready to deal with those spaces. We have appointments, for example. Appointments are a good example of why that's a barrier to access, really, because they don't walk around. A lot of our people don't carry schedules. If they have phones, they're not using them to put appointments in a scheduler. They're not using reminders to get them. When we send out reminders, many times they don't even answer because they don't want to use up their minutes on their phone. So we have to be culturally aware and sensitive to the populations we're working with. Now, I am in public sector, so my indoctrination is how to treat the least, right? But even in populations where people have more, our healthcare system is so complex that most people don't know how to navigate it and negotiate it. And so in general, people struggle with access to care. And so it's just really, really important that we are really, really real and grounded in a very humble way when we think about people and what people need when we do our planning, and we step away from what is presumed to be needed, and also think about, well, what would you want? How would you want this to work for you if you were in this situation? So access is absolutely necessary. Our people are not healthcare literate, and so they don't typically know how to negotiate services. And then our service delivery sometimes is just so encumbered by processes that a person just can't walk in and be seen, get an evaluation and told kind of what they want on the front end, what they need and on the front end. So that they can back into all the other things that we offer on the front end that really deters people from even coming in. So just being more centered around people's needs is a huge component of access to care.
Yeah, yeah. And I think all of those things, you mentioned how they are barriers, appointments, having services in places that people can actually get to them, insurance, funds, all of those things that we can see as just a part of the process being something that excludes individuals from even trying or attempting to show up for care. So what are your thoughts about when individuals do show up for care and do walk into a clinic or a facility or have like a mobile team come out to them? What are those things that you feel are important at that point for someone who is treating them, assessing them for them to know?
Yeah. So, one of the things that they taught us in one of the early memories I have of one of my supervisors sharing with me is that one of the most important things that a healthcare clinician, and in this case, physician, needs to know is when to refer. You should really be clear about when to refer, because the reality is the complexity of medicine is so broad and insurmountable. I think social media helps this younger generation to unmask more information, but the brain still can only consume what it can consume. In any case, knowing when you have reached the limits of what you can do and making sure that that person gets to see someone. When people come in, being cognizant of the fact that you have limitations in terms of what you can do, but it's your responsibility to connect them to other resources, partners, other agencies, so that they can get the rest. The other thing is we have to be mindful of our own countertransferences around people, because we all have them. We're human. We have our own prejudices. We have our own judgments about people, and we have to do the work to keep that out of the way, because that is a barrier. And many times people will come, but they will never come back because they were confronted with a mindset that did not align with what they considered to be welcoming, or in a posture of trying to really understand what's going on with me, or trying to create a care plan that is unique for me, not some cookie cutter that you are applying from someone else. So we, again, naturally, as clinicians, have countertransference operating, but we have to be intentional about understanding ourselves. So to treat also is to know thyself, and we have a responsibility to do that.
Nice. The piece about that countertransference, a word that is used quite regularly, but thinking about it in this context and how it shows up even from the beginning, as a practitioner, that's not always something that we think about. We think about how that can happen over the long term, but just making sure that we're able to think about how that starts out, I think is really important. For our last thought for today, I'm just going to ask you kind of a general question of why addiction medicine? Why addiction psychiatry? Why are we should make sure that there's space and time and information for this specific discipline?
So that you could also just you can ask me why am I an addiction psychiatrist? So I'm going to tell you that first. So okay. I was a medical student. My one of the professors who I admire the most told me in a conversation that if you're going to be a psychiatrist and you don't know addiction psychiatry, you're going to be marginal at best. And that just stuck with me, right? That stuck with me piercingly. And so I'm not a marginal person. So that really was a call to, okay, then I'll have to do addiction fellowship, right? Mm-hmm. But what's interesting, I never learned any more addiction than I learned with him as a medical student. So I finished my residency, was getting ready to finish my residency, and I felt inept So I contacted him about coming in, about doing a fellowship, and hence his guidance, fellowship, the story of my career, addiction psychiatry. Now, that's important. And why addiction psychiatry? Because it is the completion of what is really going on with this person who's sitting in front of me. Addiction psychiatry sort of, for me, puts the icing on the cake in terms of understanding what's happening here, because over 40% of the time it is there, as I said, as my lead-in. And we have to look for it with suspicion. We have to assume it's there and rule it out before we assume it's not there. So why addiction psychiatry? Because you are conditioned to think that way. That is not conditioning that you get with understanding general psychiatry, or if you're a social worker who hasn't had, or an LPC, or someone in one of the other, or an RN, or a DNP, or a nursing practitioner. If you have not had targeted, specific, intentional time understanding addiction, you don't understand addiction. I will put it out there. You really don't. And competency is a big thing in medicine because it's so complicated. So I would say, because it completes the entirety of understanding psychiatry, because we have so many people who are using substances to cope with their lives. And this is the worried well, who are functional, working every day, as well as people who are homeless. We have to understand what is going on in these scenarios that this person is deciding to use these substances. There's always a need there. People never casually use drugs. There's always a need for why people drink, smoke, and all of that. It's our job to figure that out and then to help them. I would say to them, listen, I know that you're going to continue to use. If I don't figure out something better, a better alternative for you, we already know you're going to continue. So my job is to help figure out for you what is going to be a better alternative. And sometimes that's treating the underlying psychiatric condition to help them not treat it. ADHD is a great example. Marijuana presumably helps with that, but it doesn't take care of it. You still need those stimulants and those other meds that are prescribed. But if you don't diagnose it, the psychiatric, they're going to continue with the addiction behavior. So the outcomes, compliance and care, because you're getting good outcomes, helping people move forward in those other important areas of their lives. Methadone is a beautiful medication because it restores functioning for a lot of people. And so addiction treatment is very restorative when it works. And when it's available for people, and it absolutely saves lives. So that's why addiction is so important.
Thank you.
I feel like that needs like just a mic drop.
Yeah.
But thank you so much, Dr. Rochelle, for being with us today. And I will turn this back over to Megan.
Great. Thank you, Joy. And thank you, Dr. Rochelle. Just fantastic conversation and so important. I'd love to get some reflections on our roundtable. So we have Rob Morrison, who is the Chief Executive of NASDAD, as well as Dr. Brian Sims, who's a Senior Medical Advisor at NASHBID. And so, Rob Morrison, let's get your thoughts first and your reflections on what you heard.
I appreciate that, Megan, and thanks for carving out specific time for the conversation. I'd like to recognize Dr. Dunham for her leadership. There we go. I'd like to thank Dr. Dunham for her leadership. She served on our board and was always helping other states. And we recently recognized her for her leadership of work we're doing with medical directors, specifically around substance use disorders. And I'll pick up on just Dr. Dunham's theme of being deliberate and intentional. And I think that we appreciate being deliberate and intentional in this forum to specifically talk about SUD. And then applying the idea to 988 crisis in general, And that speaks to the competencies across the board of those who are contacted through text and calls, those who are part of the mobile crisis teams, um, those then the provider network that we're constantly having to make sure we maintain and have staffing given the workforce crisis. And I know these calls have detailed those challenges well, and also solutions, or at least interim efforts as we build the pipeline. And finally, we've seen and would also appreciate other examples of specific communication strategies on the front end to help tell that story of folks in recovery, SUD in particular, the families and the family perspectives, and then the continuing care that Dr. Dunham talked about that benefits from core competencies specific to substance use disorders. So we appreciate the opportunity to continue to place a spotlight on these issues and also help demonstrate how this all complements our larger system with again, the deliberate and intentional approach that Dr. Dunham spoke about. So thanks again, Megan, and I'll yield to my colleague, Dr. Sims.
Thank you so much, Rob. Always love your perspective and really appreciate you being on. And Dr. Sims, what are your thoughts as well? And Dr. Sims, I just want to add one piece, if you don't mind reflecting on it. Dr. Dunham mentioned about trauma. If you could speak to that, I'm sure you were about to, but I'd love to.
Indeed I was. Indeed. Well, first and foremost, Dr. Dunham, I could have listened to you all day. I don't know how you get all of this information in such a short period of time, but a lot was covered then. And a lot of it touched my heart from what Megan's saying with regards to the trauma. I especially like your connection about the trauma, addictions, and homelessness. Those are key elements to any addressing of anything that we're going to be able to do. And understanding the pervasiveness of trauma and understanding how addiction is so tied to it, it becomes a key element of discussion. Now, being an old psychiatrist and being around for a few years, one of the things that has always resonated with me has been about trauma-informed care and prevention. And one of the things I just wanted to kind of throw out there is, I guess you would call it a bucket list dream of mine or whatever, but just taking what you're talking about and getting it to resonate amongst everyone is going to a statement that Desmond Tutu had a quote. And he said, there comes a point where we need to stop pulling people out of the river. We need to go upstream instead and find out why they're falling in. And one of the ways to really look at that piece is to go back and look at the healthcare facilities, the nursing facilities, the doctors who are being trained, and insert that addiction psychiatry portion, the understanding of addictions, and give them those tools so that they're better able to do it, and not only do it in a way that expresses their knowledge of it, but also in a trauma-informed fashion, so that they're better equipped to be able to work with the population we have. Because clearly those three items, the trauma, the addictions, the homelessness, these are not things that we are looking at as occurred in the past. These are things that are progressively getting worse as we speak. So it really is very timely that this topic has come up. And I want to thank you again for a wonderful presentation. Megan, I'll turn it back to you.
Thank you, Dr. Sims. I always love the roundtable because it just gives that time to deepen and get those perspectives in there. So thank you all for the presentation as well as the reflections. We are now going to shift to the briefing room. And as you know, SAMHSA will not be on because of the government shutdown right now. So we're going to shift to the NASHBID briefing and some NASHBID remarks. And super happy to have Justin Volpe on. Justin is the Senior Peer Support Coordinator at NASHBID. And Justin, just thrilled to see you. Go right ahead.
Thanks so much, Megan. I really appreciate you guys inviting me to the show this week. Man, so much great content tonight. To follow up on Dr. Dunham and talk about some of the barriers, right? Where are the barriers in the community where people aren't getting treatment? This is where peer specialists come in. support, provides support, and reduces recidivism and relapses. We're here to bridge the gap in the community when people can't make those appointments. When, I made a comment in the chat, the system is hard enough to navigate as somebody that's not going through crisis or addiction, right? And when we look at people not accessing care in this country that suffer from addiction, they're ending up incarcerated, right? We still have the largest percentage of people incarcerated in this country. And most of people have suffered from trauma and addiction. And we need to, really bridge that gap and start having these conversations. No, peers can't solve everything, but we're part of the solution to work with teams and to break that surface, to start with a conversation. We live in a country of addiction. Maybe yours isn't substance uses. Maybe it's Amazon. Maybe it's Netflix. Maybe it's a unhealthy diet. We all seem to be trying to fill that void, and we have to work together to help serve the population better. And in that, peers need to play a better role and keep their roles to what they should be and not be coercive in treatment. We're here to help guide, but ultimately, when somebody's ready to make a decision, they do make that themselves. We can have all the support, have all the things lined up, but that person still has to walk through that door. And we need to make the system easier, like Dr. Sims said, preventively, so people are able to do that and not end up incarcerated in jails or furthermore death. And it's that I put two links in the chat. Worked recently with Arkansas. They do a lot around addiction peer support. Some highlights of their three-tiered peer program in the chat, and a video of myself working with the jail diversion program, doing peer support in the community with people that are criminal justice involved. We also, are working with the least here. We can't continue to cut resources and expect better results. We need more approaches. We need more open doors. And with that, I pass my time back to you, Megan. Thanks for having me on the show.
Justin, really appreciate you and your leadership. One of the things about Justin that is so refreshing, he can relate to so many different kinds of people. He just draws people to him. He's just so super. And every time Justin talks, he's just very engaging. People want to hear more and more and more. So Justin, thank you for being on. Really appreciate it. So we are now going to pivot to Advocates for Human Potential. I'm going to hand this over to Miriam Delphin-Rittman. And Miriam, we just so appreciate the partnership of AHP. This is our Workforce Corner. So thank you so much for being on. Please go ahead.
Yes, thank you so much. Thank you for having us on. And we are thrilled to be able to provide this segment, the Workforce Corner. Thrilled to be able to do this on a regular basis. And I have with me today Susan Lang, who is the director of the AHP Workforce Innovation Lab. And Susan's going to talk a little bit about some of our workforce activities and some of the work coming out of the Innovation Lab. So Susan, happy to turn it over to you.
Thanks so much, Miriam. Hi, everyone. I'm really excited to be here. I'm going to talk for a few minutes today about some work that we've been doing with the crisis centers and really dig in around workforce issues. So we know many of you may remember those old Got Milk commercials. Well, in workforce, we say got people, and if you don't, you're not going to be able to get the work done. So that's critical to what we do. I'm going to start with a quote that is from an administrator in a county crisis line in California. And this person really spoke to, not getting big wins in the crisis work, but it's the small wins every day and how important that is. And I'm also, I think what you said, Dr. Sims, really struck me from the quote from Desmond Tutu. Instead of pulling people out of the river, you got to go upstream to figure out what's going on. And in workforce, we've been doing just that and really digging in around the data to understand root cause in terms of where folks are. So next slide. So we use a data-driven approach to understand what's going on in the workforce. We want to do a root cause analysis to see what's driving workforce challenges. So we know within the crisis continuum, that retention is an issue. And then when retention is an issue, recruitment can also be an issue. And then making sure that there's an effective pipeline strategy is really, really important to make sure there's a steady flow of workers coming into the system. So we really look at data from multiple angles. So let's go to the next slide. This is the way that we have been digging in to understand what's going on in the workforce. So we start by describing the current continuum workforce. We do environmental scans. So we look at what is happening in the system. Where is the literature saying there are trouble spots as the first point of entry? We're looking at workforce demand and shortages and future needs and labor market outcomes to gather some baseline data. We map out career pathways that include both entry points and exit points in the workforce and identify what the key skill gaps are. We often see when we're mapping career pathways, there are many, many entry points and the system is not mapped. So for folks who might be interested in this field, they have no idea where to get started or what the upward trajectory might be for them. So mapping that out and having a clear pathway for folks helps them to better understand what the system is, where they may enter, and what the upward mobility avenues could be for them. Aligned with that is looking at the academic pathways and thinking about through partnerships and programs, what is available to folks to get in, to get credentialed, to get certified, to increase their academic background so they can move within the system. And oftentimes that is not clear either, so that configures into the mapping. And then in the data, we do both quantitative and qualitative analysis. So we conduct key informant interviews to identify gaps in the workforce. We want to hear directly from people who are doing the work of the work to tell us what's going on. We know writ large that burnout is an issue and turnover is an issue, but what might be driving burnout or turnover can be really different county by county or state by state or organization by organization. And so we want to identify what the challenges are so then we can solution against what the root cause problems are rather than having a one-size-fits-all solution. And then with that, we are doing the quantitative analysis too. So we're serving folks as well as doing the key informant interviews and focus groups. The thematic analysis, so here's just some big picture things that from doing this data work that we know are challenging. So sustaining and expanding the crisis services workforce, it's a dual focus, so structural investment and human-centered support, really grounding the work of the work and listening to folks who are doing that work. That came up last week in the session. And then prioritizing staff wellness. Funding is an issue, we know, but we also know that folks will stay within their roles and in the system if the work is meaningful. So we will continue doing these workforce corners once a month, and we'll dig into these topics much, much more in the future.
Susan, thank you so very much. It's wonderful to have you on. And I'm going to turn this over to Kristen Ellis.
Thanks so much, Megan. And thanks to Rochelle and Joy for that awesome fireside chat. Took me right back to my practicum days where I learned more about people when I was working with people than any classroom could ever teach me. Again, thanks to one of our headliners, AHP, for keeping this jam stage lit. If you want to be a sponsor, please reach out to us. Next week, we have Dr. Kelly Posner about Columbia protocols in crisis care. In 2 weeks, we have Dr. Stephen Schuler on mental health apps and AI. We're really grateful for all of you joining us today. So we want you to tune in, log on, and you can join the movement. And we will see you all next week.